My name is Thomas-Troupe. I am a graduate dietetic student at Eastern Illinois University. This is my systematic review for Research Methods in Nutrition 5600. My presentation is on faith-based interventions for chronic diseases in the African American community. I chose this topic because African Americans have the highest rate of developing chronic disease than any other population, and my family is also deeply rooted in the church. My father-in-law is the apostle of our church. Many members in my family and my church members have been diagnosed with hypertension, diabetes, chronic disease, cancer, or a combination of disease states. This review was done with the intent of finding an intervention that could be utilized in my church to help my family and church members work together to better manage their health. This is the outline for my presentation. First, I will give an introduction on the prevalence of chronic diseases in the African American community. Then I will discuss how religion plays a part, whether positive or negative, in African American churches. I will give a brief lit review on my 10 sources, after which I'll do a brief discussion on what I found in the studies that I researched and list the strengths and weaknesses of those studies. I will then discuss my conclusions and then answer any questions. Chronic diseases is often preventable through early detection, exercise, and a healthy diet, but when left untreated, it can lead to a decreased quality of life and even death. The U.S. government spends billions of dollars per year to reduce or prevent chronic diseases. 90% of the nation's healthcare budget is spent on reducing or treating chronic diseases, yet it remains the leading cause of death in America. Because we are all grad students, I will not go into detail about each disease, but I will briefly provide some background on the prevalence of each disease and death rates in the African American community. It is a known fact that being obese increases the risk of developing all other chronic diseases. As you can see, compared to other populations, African Americans have the highest rate of obesity. A factor in reducing obesity is physical activity. According to the Office of Minority Health, African Americans are 20% less likely to exercise than whites. For African American females, one of those reasons would be the amount of time it takes for us to do our hair. So you wouldn't want to sweat your hair out and then have to spend hours to redo your hair. 30 million people are diagnosed with diabetes every year, type 2 diabetes being the most common form of diabetes. Minorities carry the highest risk for developing diabetes, but African Americans are diagnosed at a larger rate than other populations. As you can see, African Americans have a 77% higher risk of developing diabetes than whites. That rate is the highest out of all minorities. Almost half of Americans have one of three risk factors for heart disease. Those three factors would be hypertension, high cholesterol, or are smokers. 23.8% of Blacks and whites die from heart disease, but when you take in consideration that only 14.6% of the American population is Black, it's clear that more Blacks die from heart disease than whites. The prevalence in cancer. African Americans are also more likely to die from cancer. Breast, prostate, stomach, cervical, and lung cancers have the highest death rates for African Americans. By encouraging more African Americans to become physically active and include more fruits and vegetables, and also reduce the amount of fat in their diets, the trend of having the highest disparity for death from a chronic disease can start to trend down. One way to combat this issue is through the church. The church is a major part of the African American community. Blacks spend at least 3 days a week in a church, and there can be more. These days consist of Bible classes, church service, and prayer meetings. The pastor is highly respected in the church. The congregation seeks his spiritual advice on majority of their concerns. The meals served for special occasions, such as anniversaries or church programs, are usually centered around the food preference of the pastor. These meals also tend to be high in carbs and fat. Religion can have a positive or negative influence on health. The pastor can encourage healthy eating habits by directing what type of meals should be served in the church. Pastors can also help to build trust between members and healthcare providers. A majority of older African Americans do not trust doctors. They believe that when they go and see their primary care physician or specialist, that they're not listening to them and just want to get them out of the way so they can be paid. Or if they're seen in the emergency room, there's a fear of the hospital staff will allow them to die so that they can harvest their organs. There can be religion can have influence on cultural body images. In the African American community, greater weight, or the bigger a person is culturally more appealing than being thin. So a lot of African American women don't see it necessary to lose weight because they're afraid of losing their curves. So the church can influence weight loss on a health aspect and get the culture to look away from curvy as being sexy but more so a healthy weight being healthier. It can also influence optimism towards treatment. So if you combine prayer with medical advice, it increases the success rate of treatment, and less people would die from chronic diseases that can be prevented. But religion can also have a negative effect because members will not seek treatment because they are relying solely on prayer and fasting to be healed from their conditions. The purpose of this presentation is to increase the knowledge on the use of faith-based interventions in the African American church and their effects on reducing chronic disease. This was in hopes to answer the question, are faith-based interventions more effective in reducing chronic disease than traditional methods in the African American population? For my research, I use EBSCO through the EIU library and PubMed to search for sources. Using the two databases, I was able to locate 186 sources total using the keywords African American, Black, church, interventions, and faith-based interventions. I then screened those sources using the inclusion criteria of being within 2009 to 2019, peer-reviewed journals, African American churches, African American participants, and sources had to contain interventions. Sources were excluded if they were not within 2009 to 2019. The interventions were for HIV and AIDS because I wanted my sources to be able to be cured through diet and exercise, or if they were for mental health, not peer-reviewed journals or duplicates. This left me with 22 sources. Then the next step was to remove any sources that were not full text articles. I was then left with 10 sources for my review, and an example of my prism will be shown on the next slide. This is the example of the review process I just described in the previous slide. Article 1, Sisters in Motions, a randomized controlled trial of a faith-based physical activity invention by Drew, Sarkisyan, Ling, and Mangong, 2010. The primary focus was on physical activity and blood pressure. This was a randomized controlled trial utilizing 3 churches in California with 71 participants. The intervention was for 8 months. The participants met for 90 minutes weekly for 8 weeks, and a follow-up consisted of monthly meetings for 6 months. The purpose of this study was to evaluate whether an increase in exercise would improve blood pressure, increase weight loss, and reduce chronic pain when combined with faith-based curriculum. Eligibility requirements: the participants had to be African American, female, age 60 or older, not physically active, which means they were exercising less than 150 minutes per week, and able to walk without assistance. The intervention group included reading scriptures, prayer before and after class, goal setting, and 45 minutes of exercises. The control group received 45 minutes of exercise and lectures on unrelated health topics. Both competed in step competitions. The results: at the end of the first 8 weeks, there were no significant difference between groups. At the end of the 6-month follow-up, the intervention group reported more steps and their blood pressure decreased compared to the control group, but it was not enough to be considered statistically significant. Article 2, Increasing Physical Activity in Black Women, Results from a Randomized Trial Conducted in Faith-Based Settings by Wick Glover et al., 2017. The primary focus was on physical activity for this intervention. This was a cluster randomized controlled trial using 31 churches in North Carolina. There was 443 participants. The intervention was for 22 months. The participants met weekly for 4 months, bi-weekly for 2 months, and then monthly for 4 months, followed by a 12-month intervention. The purpose of this study was to evaluate if faith-based interventions would be more motivational in getting participants to exercise and continue to exercise compared to secular and self-guided interventions. Eligibility requirements: the participants had to be African American, at least 18 years old, and members of the churches. The intervention groups included scripture and prayer, group exercises, and goal setting. The secular group received group exercises and goal setting, and the self-guided group were given a handout on exercises to follow for the 10 months. During the first 10 months, both faith-based intervention and the secular groups significantly increased their steps compared to the self-guided participants, but the intensity of the exercise did not increase. So that meant they walked for those 10 months, but they did not walk faster. They just kept the same pace. All 3 groups reported an increase in steps, but there were no statistically significance between the 3 groups. During the 12th month follow-up, the participants were to maintain their physical activity. The faith-based intervention and the secular groups both decreased in steps, but they still walked more than the self-guided group. Overall, there were no statistically significance between the 3 groups. Article 3, Community Trial of Faith-Based Lifestyle Intervention to Prevent Diabetes Among African Americans by Satin et al., 2016. The primary focus was reducing weight, fasting glucose plasma, and increasing physical activity. The intervention was for 12 weeks. Participants met 1 hour weekly for 12 weeks and 1 hour monthly for 6 months. Community-based participatory research was used for this intervention. CBPR allows the participants to be involved in all stages of the project. 20 churches were placed in pairs and randomized into faith-based intervention or health education. Participants did not know which group the church had been assigned. Members from community and university boards, the body soul trial, and church members designed the intervention. Eligibility requirements were the participants had to be African American, between the ages of 24 and 64, non-diabetic, have a BMI of greater than 25 kilograms, and no physical limitations. The fasting plasma glucose had to be less than 126 milligrams per deciliter. The intervention group received classes on reducing calories, reducing fat intake, physical exercise, goal setting, and problem solving. The control group received classes on risk improvement for mental health, stress, heart disease, stroke, diabetes, cancer, smoking, violence, and HIV, and also on talking to their healthcare providers. The lessons were delivered by the church health advisors. The CHAs worked in the health ministry and were trained by a group that performed the lifestyle balance program on reducing diabetes. Assessments were taken at baseline, weeks 12, 14, and again at 12 months. To note, 15.2% of the participants had pre-diabetes at baseline. The results were 13% of the faith-based intervention group had a 7% weight loss, and 3% of the health education group had a 7% weight loss. There was no significant change in the fasting plasma glucose for either of those groups. There were improvements, however, in the pre-diabetic participants. Those participants had a 12.38 milligram per deciliter decrease compared to a 4.4 milligram deciliters for the health education. So the faith-based group had a 12.38 decrease, and the health education had a 4.4 milligram decrease. But there was still no significant changes in physical activity for either of the groups. Article 4, Dash of Faith, a faith-based participatory research pilot study by Harmon, Adams, Scott, Gladman, Azale, and Herbert, 2014. The primary focus for this intervention was for fruit and vegetable consumption and fat reduction. This was a quasi-experimental program that utilizes 2 churches in South Carolina with 23 participants. The intervention was for 8 months. Participants met weekly for 12 weeks and then monthly for 4 months. This intervention was based off of the 2004 Body and Soul program that focused on changing diet by working with the individuals in church. The pastor, first lady, and other church leaders helped to design this intervention. Eligibility requirements were that participants had to be African American and 18 years or older. One church was assigned as the intervention arm and the second as the control. The repass committees who made up the participants in this study were the church members who planned and cooked the meals for the church services and programs. They were trained with giving they were trained on how to cook healthy meals, and then they also had meetings to discuss barriers to healthy meals at the church. The control group was giving classes on cancer, but to note, at the end of the study, they were given the same training as the intervention. The assessments were taken at 2, 4, 6, and 8 months. The intervention group had a large increase in fruits and vegetable intake by the 6th month, but they did not maintain that increase by the 8th month. And the control group did not have any improvements by the 8th month, and they also decreased by 29%. Fat consumption decreased by 8% for the intervention group, and the control group had a decrease by 4.3%, but the researchers found that they couldn't figure out why there was such a large reduction, and they took it as being because it was self-reported. The intervention group had a 1.5 reduction in body fat, while the control group had a 0.8% reduction, which indicated that this intervention was not statistically significant. Article 5, the FAITH trial, baseline characteristics of a church-based trial to improve blood pressure control in Blacks by Schlossberger et al. 2015. The primary focus of this intervention was blood pressure, physical activity, and fruits and vegetable consumption. This was a cluster randomized control trial. The intervention was for 6 months. The participants met for 90 minutes for 11 weeks and 30 minutes for 3 months maintenance. This intervention evaluated the effects of faith-based intervention versus health education on blood pressure. Each churches provide 3 church members to act as lay health advisors who delivered the intervention program. Lay health advisors participated in a 2-day motivational interviewing training. Although each church were randomly assigned as an intervention or control group, this was not a blind study. Recruitment was done by flyers, posters, church announcements, and bulletin boards. The faith-based intervention group included prayer and scripture prior to and after the group meetings, and discussion points on health in their group sessions. The control group was given a booklet on reducing blood pressure and 11 weekly sessions that were led by nonprofit organizations for the first session, and the remaining session consisted of health topics unrelated to hypertension. Blood pressure was assessed at baseline, 6 and 9 months. Physical activity and fruits and vegetables was assessed at baseline and 6 months. Fruits and vegetables and physical activity were self-reported, and the participants had a reported increase in fruits and vegetables, but it was still below the daily recommended levels, and there were no significant reduction in blood pressure. Article 6, Adoption, Reach, and Implementation of a Cancer Education Intervention in African American Churches by Santos et al. 2017. The primary focus for this intervention was on health promotion using traditional methods versus web-based methods. This was a cluster randomized trial utilizing 15 churches in Maryland, and there were 375 participants. The intervention consisted of 3 workshops. Participants completed 3 modules with a choice of one 6-hour class or 2 3-hour classes per module, and then there was a 12-month follow-up survey. Community-based participatory research was used for this intervention. CBPR allows the participants to be included in all stages of the project. The churches were recruited through a nonprofit organization and were randomly assigned to either the traditional teaching or a web-based teaching. The CHAs were 1 male and 1 female that was selected by the pastors, and they led the 3 educational workshops on breast, prostate, and colon cancer. Eligibility requirements, the members had to be at least 25. The participants had to have at least 25 men and 25 women. Participants had to be between the ages of 40 and 75, and they could not have had a diagnosis of cancer within the past year. The CHAs either received the traditional 13-module training or the web-based training, and both had to pass with at least an 85%. All the churches completed the 3 workshops, but the traditional group took longer. It took them 84 days to complete 3 workshops, and the web-based took 64 days to complete. The workshops were able to educate at least a third of the church members on cancer prevention. The CHAs reported a positive rating for the intervention and participate engagement in both groups. Article 7, Partners Reducing Effects of Diabetes Predict. Diabetes prevention, physical activity, and dietary intervention through African American churches by Faridi et al. 2010. The primary focus for this intervention was diabetes prevention. This was a non-randomized controlled trial utilizing 19 churches in Connecticut. There were 39 CHAs and 161 participants. This was a 12-month intervention taught by the CHAs, who had received 10 weeks of training before leading health education and diabetes prevention classes. This study was done in collaboration with the community participatory team of local churches, community organizations, and health department. Pastors selected members of their church to train as church health advisors. The CHAs had 10 weeks of training on diabetes prevention and were responsible for recruiting the participants from their church, as well as implementing the classes. Eligibility requirements were that participants had to be 18 years or older, African American, a resident of Connecticut, and also the members of the participating church. And they had to have diabetes or were at risk for diabetes. CHAs elected to combine the education classes with Bible studies, while others chose to reach out individually to participants. Community outreach events were held during interventions by some of the CHAs. There were no clear guidelines in how the interventions were to be administered in each church, and many of the participants did not complete their intervention. The results indicated no significant improvements between the groups in knowledge, BMI, diet, or physical activity from baseline to post-intervention. Article 8, the Faith, Activity, and Nutrition Program, a randomized controlled trial in African American churches by Wilcox et al. 2013. The primary focus was physical activity, fruit and vegetable consumption, and blood pressure. This was a group randomized controlled trial utilizing 74 churches and 1,257 participants. The intervention was for 15 months. This study was conducted from 2007 to 2011, utilizing community-based participatory research methods. Each church established a committee to attend an 8-hour training. They also received 15 months of assistance to support the program. Eligibility requirements were that participants had to be 18 years or older, have no previous medical conditions or disabilities, and attend church regularly. The committee consisted of the pastor, a health director, and a cook. The committee also developed the intervention program for physical activity and healthy eating. Bulletin boards, pulpit messages, and educational handouts were implemented to encourage participation in the program. The results: physical activity increased in intervention churches, but decreased in control churches. Fruits and vegetable increase in the consumption increased in the intervention churches, more so than in the control churches, and there was no significant change in blood pressure for either of the groups. The evaluation from the committee was positive. Participants liked the hands-on aspect. They liked the exercise and the recipes and what they thought they learned from this intervention. The results were not significant, but the educational reach to 36,000 members from 74 churches could make a possible impact on public health. Article 9, Implementation of Fit Body and Soul, a church-based lifestyle program for diabetes prevention in high-risk African Americans, a feasibility study by Dodani and Fields, 2010. The primary focus for this intervention was weight loss and diabetes prevention. This was a non-randomized controlled trial utilizing a church in Georgia with 40 participants. The intervention was for 12 months. Participants met for 12 weekly 1-hour classes, and then there was a 6-month 1-hour follow-up classes. This was a modified Fit and Body Soul program. Four church ministers participated in a 2-day training on Fit Body Soul program. 12 weekly sessions were delivered by the church health advisors to everyone interested, but data was only collected for those selected to the program. Eligibility requirements were that the participants had to be members of the church, age 18 to 64, African American. They did not have diabetes, but had a BMI of 25 kilograms. And then they also had to have a letter of health, a letter stating they were in good health by the primary care physicians. Results were 48% of the participants lost at least 5% of body weight from baseline, 26% lost 7% or more, and 14% lost more than 10% of weight. Article 10, The Life Project, a community-based weight loss prevention program for rural African American women by Parkers, Cole, Logan, and Davis, 2010. The primary focus was on weight loss. This was a pre-test, post-test design utilizing 2 churches in South Carolina, and there were 28 participants. The intervention was for 10 weeks. The participants met for 10 weekly 90-minute classes for education on weight loss. This study was conducted based off of a previous study called Project Joy. 2 churches were recruited by the county extension educator. One was designated as a spiritual arm and the other as a non-spiritual arm. The extension educator led the intervention classes during the 10 weeks. The eligibility requirements was that participants had to be 25 to 64 years old, African American, not pregnant, not lactating, and attend all sessions. Statistically significant results for weight and blood pressure were reported for the non-spiritual arm. Statistically significant results for weight, blood pressure, BMI, and physical activity, and communications with their physician was reported within the spiritual group. Out of the 10 sources for this systematic review, there were a total of 199 churches that participated and 3,374 members. 8 of the 10 studies were randomized control. The results showed that while physical activity and fruit and vegetable consumption increased, but there were no significant results in blood pressure, weight, or BMI. And this could also be a results because the studies were pretty short and they were self-reported. All 10 studies utilize the pastors and the ministry staff to design and implement the interventions. That was to keep the church, the faith-based intervention in line with the church. And all 10 studies had a problem with keeping participants engaged through the entire intervention. And sustainability was an issue because once the studies were done, a lot of the participants couldn't maintain what they had gained or lost by follow-up. So those had changed. For my discussion, faith-based interventions are not new. In the last 10 to 20 years, there have been quite a number of interventions and pilot studies done on African American churches. What has been established by these interventions is that by implementing nutrition education in churches, the ability to reach this high-risk group has increased. These 10 interventions alone were able to teach in 199 churches and provide nutrition education to over 3,000 people. RDNs who collaborate with their community churches will provide a much needed nutrition education to this and many other high risk groups who do not respond to traditional methods. A limitation for these interventions were the sample size. Out of the 10 interventions, only 3 of them had more than 100 or more participants. The rest of them were under 100 individuals. Limitation was the rate of change. Participants were not ready to change their lifestyles, so they either dropped out during the intervention or they did not complete the follow-up. Another limitation was recruitment. The researchers had a hard time getting church to participate because of The church calendars, they were pretty busy and didn't want to take the time out. They also didn't have enough staff who were willing to take time out of their day to help implement the programs. So that made recruiting kind of hard. And another limitation was that the studies were mostly women, which also is kind of hard because majority of the African American churches have predominantly women members. Strength in these programs was that there were health professionals within the church that were using these interventions as well. There was noted that there were nurses, doctors, and a couple of phlebotomists that were able to be utilized in these programs. Another strength was the focus on high-risk population. Trying to solve the problem of chronic disease in high-risk population is a strength. The flexibility was also another strength, because those churches who were able to participate, the researchers were able to work around their calendars and their obligations during the week, whether it be the Sunday services, the Tuesday night Bible classes, their prayer meetings, or any outings they had to go to when fellowshipping with other churches. Another strength was the coverage and the focus on multiple conditions. So they didn't rely on just one. They focused on diabetes, but also on the obesity and the high blood pressure to that effect, that so that it was multiple conditions were treated during this intervention. Weaknesses. All of the studies had the weakness of self-reported data. Every study utilized either food logs, exercise logs, or utilized telephone calls to the individuals or surveys. These allowed the potential for the participants to increase the information to make it seem like they were doing more than they were, or to decrease this to show that they were making a substantial impact in whatever variable that they were looking at. Also, the potential for bias was present in each one of these studies, mainly because the participants were selected by the pastors, and also the people who were put in charge of implementing the interventions were also selected by the pastors. So that got the potential of those individuals showing favoritism towards who was going to be in this study and how they treated those individuals. Another limitation was on attendance. Although majority of the participants agreed to be at all of the interventions, a lot of them dropped out midway through or did not follow up with the follow-up intervention. There was missing data. That was a weakness. That was also from participants not following through with intervention or the follow-ups. The short intervention periods, there were a lot of participants that their intervention was a year long, but the intervention period was only 8 or 9 months. Compensation was not sustainable. A lot of the participants were given gift cards or were put into drawings for gift cards, and if the interventions would have gone longer, they probably would have ran out of funds. And if that was the only incentive for being in a study, if you took that away, you wouldn't have had enough people to participate. And the studies did not focus on other settings outside that influence behavior, such as the family home, workplace, or the areas that the participants lived in. In conclusion to the question, to answer the question, are faith-based interventions more effective in reducing chronic disease than traditional methods in the African American community? The results are inconclusive. There need to be more long-term studies done on faith-based interventions and see what the effects are on chronic diseases. Implications for future research and professionals. Future research could include interventions in all churches. As we saw in the beginning, the prevalence for chronic disease is not limited to African American churches, so including different other ethnicities such as Asians or Hispanic churches could reach an even broader high-risk groups. Also including white churches. It's not as though they are exempt from chronic diseases. Another avenue is to reach community centers. A lot of people participate in their local community centers. This would also help to reach a broader audience and increase the reach of teaching nutrition educational information. Another aspect is to find a way to increase male participation. Although the church is great, we should know that it's predominantly females who are members to churches, especially in the African American community. And there has to be a way to reach male participants because they are at a higher risk and die at greater rates than any other than females. Okay, the implication for professionals are to make sure that you are collaborating with your local churches. See if you can establish a relationship with them so that the members, and especially in the African American community, will develop a trust or a bond that will allow you to teach and make a greater impact in chronic diseases. I would like to thank you for watching my systematic review. I hope that you learned something new today, and I look forward to answering any questions that you may have. Thank you.